I want you to know for each cranial nerve, there's 12 pairs. I want you to know the number and the name associated with it, the number in Roman numerals. We're going to talk about the functional components. Many nerves have just one. Some nerves have more than one, and I need you to know the ones that I list. And then those functional components, if they're sensory, I need you to know, where's the sensation coming from. If there's a motor target, I need you to know what that is. Okay, so like that. So some of these nerves will have both sensory, some will have motor, some will have both. Okay. Also, down at the bottom, I'm going to have a little text that discusses how you would test for the function of a cranial nerve to make sure it was working okay, and how an injury to the nerve might affect a patient. So cranial nerve 1 is the olfactory nerve. Very simply, it brings olfactory sensory information from the top and back of the nasal cavity, where the receptors are located, into the brain. That's cranial nerve 1. It's that simple. You test to make sure someone's first cranial nerve is functional. You test their ability to detect an odor. And if there's a lesion to cranial nerve 1, you end up with some degree of anosmia, which means you can't smell anything. That makes mealtime kind of a drab, dreary affair. This is an image from Complete Anatomy that shows the first cranial nerve. It's actually not one unified nerve. It's a whole bunch of tiny fascicles. Remember, fascicle is a word that means bundle. We use it for muscles, myocytes. We can use it for nerves and axons too. So basically, the first cranial nerve is actually a whole bunch of tiny little nerves that come from the nasal cavity up through the skull, and then they get to this structure, which is part of the brain. So you can see them in pink there, kind of through the ghosted bones. Cranial nerve 2 is the optic nerve, and it brings vision from the retina into the brain. The way you test a patient's second cranial nerve is you test their visual acuity. The Snellen eye chart, that's a test of cranial nerve 2. If you lesion cranial nerve 2, the optic nerve, you end up with some degree of loss of visual acuity. If it's really bad, you're blind. And this is an odd thing. Cranial nerve 2 isn't really a nerve. It's truly a tract, which is the term that we reserve for a bundle of axons in the central nervous system. Why do we care? My point is that cranial nerve 2, by its embryonic origins and clinically relevant, is technically not a PNS structure, but really belongs with the CNS, and yet we classify it with the cranial nerves because a long time ago somebody didn't know any better. So the fact that it's truly a central nervous system bundle of axons, even though it looks just like a lot of other cranial nerves, means that the myelination is a different flavor. So the peripheral nervous system has one type of myelination, the central nervous system has another. The fact that it's myelinated like a central nervous system structure means that it's susceptible to certain central nervous system disorders, and the killer one is multiple sclerosis. So multiple sclerosis is a chronic progressive disorder that affects the myelination of nerves, of tracts in the central nervous system, including this one, cranial nerve 2. Multiple sclerosis doesn't affect nerves, other cranial nerves like nerves 3, 4, 5, etc., because the myelination is different. Okay? So cranial nerve 2 is somewhat uniquely susceptible to, among the cranial nerves, is susceptible to multiple sclerosis, which means you can have an attack and lose visual acuity or even go blind in usually one eye. It's usually unilateral at a time if you have an MS attack. There's the optic nerves. They are very large, can't miss them. Very large, going from the brainstem going from the retina back to the brainstem there. Cranial nerve 3, the oculomotor nerve. It's named because it moves the eyeball. Its functions include somatic motor to a bunch of extraocular muscles. That's the term we use for muscles that are strapped across the eyeball, and they maneuver the eyeball so that you can, without moving your head, you can look at different points in space. The oculomotor nerve has another component, though, an important one. It's a visceral motor, happens to be parasympathetic component. And I didn't talk about this. For the visceral motor pathways, they almost always use a 2-neuron chain. So there's one neuron that goes to a ganglion, which is a collection of cell bodies. These cell bodies belong to the second neuron that goes out to the target. So you're going to see ganglion in here. Every time you see parasympathetic motor, there's going to be a pit stop at a ganglion where the first neuron talks to the second one. I'll let Tim's going to talk about the autonomic nervous system later in the course, and he can elaborate on that. But the point here is that the oculomotor nerve has not just doesn't stimulate just skeletal muscle like the extraocular muscles. It also stimulates smooth muscle in the intraocular smooth muscle. The smooth muscle that controls the iris. The iris is the colored part of your eye. Jason and I have brown irises. Tim has blue. I think, Jason, you're brown, right? And then the smooth muscle that controls the lens for refraction. If your pupil constricts, if the iris constricts to make your pupil small, that's a function of this part of this cranial nerve. If your lens gets rounder so that you can focus on something up close like this, that's a function of this part of the oculomotor nerve. Lesions to the oculomotor nerve, well, the way you find out if someone's oculomotor nerves are working is you keep their head still, and then you move a target around and you have them follow it with their eyes. And if they have trouble doing that, there are actually 3 cranial nerves that control extraocular muscles. This is one of them. This is the main one. So if you have and then you can test their response to light. It's a quick test. You flash a pen light in their eye, and their pupil should constrict because of this right here. And if it doesn't constrict, something's wrong. So injury to cranial nerve 3, the oculomotor nerve, can lead to diplopia. That's the term for double vision. And the problem is, if you can't steer one of your eyeballs correctly, then your eyes are going to tend, under certain circumstances, your eyes are going to be looking at different points in space when they're trying to look at the same thing. And that causes double vision, which is very disconcerting and kind of dizzying for patients. They'll definitely come complain about double vision. You'll see mydriasis, which is the clinical term for a dilated pupil. The pupil can't constrict. And photophobia, because the pupil can't dilate. And bright lights really, it's kind of irritating and painful. And cycloplegia is the clinical term for when you can't make your lens rounder and focus on something up close. So basically anything up close is going to be really blurry. So those are some consequences of damage to third cranial nerve. And here they are. They're much smaller than the optic nerve, but you can see them tracking out from the brainstem toward the eyeball. And you can see right there, it's innervating one of those muscles, one of those extraocular muscles. Cranial nerves 4 and 6. These are kind of way down low on my list of nerves that I want you to understand. List of cranial nerves. These are 2 really small nerves, and each one of them has just one job, which is to innervate just one extraocular muscle. So the oculomotor nerve innervated, there's basically 5 muscles around the eyeball that it innervates, and then I guess it got tired, and there were 2 left, and so these 2 nerves took over, and each took one. So there's one extraocular muscle that each of these nerves stimulates. They're called the trochlear and the abducens nerves. If you have a problem with one of these nerves, you can find out by testing a patient's eye movements. And if one of these nerves is lesioned, you'll have some version of diplopia, which is double vision. Yeah. Here's the 4th nerve right here. It's really weird. It comes off the back side of the brainstem, which is unusual. Super skinny. It goes to one muscle. Here's the abducens nerve right here, also pretty small, bigger. This one's actually, here's the brainstem in back. This is going from posterior to anterior into the orbit right there. And it's stimulating that lateral muscle right there. So you'll get a better image of these when you look in complete anatomy. There's kind of not a lot of room here on the screen for those. The trigeminal nerve is clinically really important. Trigeminal means 3 twins, kind of a strange name. But it's named that because it has 3 major parts. The first part here is called V1. And we're stuck with Roman numerals. This kills me. You have to use Roman numeral 5 here as a V because a long time ago, everyone started calling the 3 parts of it V1, V2, and V3. And now we have to use the V, right? So Roman numeral 5 is V. This nerve, its main job is to bring somatosensory information. What's somatosensory information? Touch, pressure, temperature, pain. Okay, those 4. It brings somatosensory information from the face and the structures deep to the face, like the orbit and the nasal cavity and the oral cavity, right? So V1 is up high. It's called the ophthalmic division because it brings information in from near the eye. The skin of the forehead, the eyelids, and the orbit deep to your cornea. Very important. The most exquisitely innervated real estate on the body, your cornea, is innervated by a branch of this V1 ophthalmic part of the trigeminal nerve. V2 is called the maxillary division. That's named after the bone here that your upper teeth are in. So it innervates the skin of the cheek, side of the nose, your upper lip, and inside your nasal cavity and your palate up on top of your oral cavity. That's all innervated by V2. And then somatosensation from down low on the face, but also including the external ear and kind of a strip going up the side toward the temple. This is the job of V3, the mandibular division of the trigeminal nerve. And it brings sensation from all these spots, including the oral cavity and the front part of the tongue. The back of the tongue is done by somebody else. There is an extra part to V3 though. Check this out. V3 also carries motor commands out to muscles of mastication. Mastication means chewing. So basically when you eat, you're using V3 to stimulate a lot of chewing muscles. The way you test someone to see if cranial nerve 5 is okay is you test their somatosensation on their face, and you test their bite strength. Can they bite down on on a tongue depressor? A lesion of the trigeminal nerve can lead to numbness, which is a negative symptom or sign, symptom, where you've lost some function, or it can lead to pain, which is sort of a gain of function, like excess somatosensation, tingling, and it can lead to difficulty chewing if you've injured the part of the nerve that's the V3 part of the nerve that does muscles of mastication. There's a really wicked, painful condition called trigeminal neuralgia. Trigeminal nerve for the trigeminal nerve, and algia means pain, like analgesic is a painkiller. Right? This is a chronic situation where you have these sudden, abrupt attacks of super shocking pain to your face. And the pain is like 10 out of 10. It's really bad, and definitely merits therapy. It's very debilitating. Patients with untreated trigeminal neuralgia tend to go into depression. It's really frustrating. So there's the trigeminal nerve. It's huge. It's sort of in competition with the optic nerve up here for the biggest of the nerves. Trigeminal nerve is here, and you can see V1 going up top, V2 is kind of middling, and V3 is going down toward the mandible there. Okay, so that's the trigeminal nerve. The facial nerve, nerve 7, is named. It has a couple of functional components, but its most famous one is somatic motor output to the muscles of facial expression. So our facial expressions are generated by muscles that move the skin of the face, and this is the nerve that simulates them. Interestingly, there's a really big salivary gland located near your ear. Parotid means next to the ear. And this nerve goes right through that gland. It's weird. Like, I don't know why it does that, but the nerve just literally shoots through the gland. And that means that if there's trouble with the gland, it can cause trouble with the nerve. So if you have a tumor in the gland, or if you have if the gland gets stopped up by a stone, which can happen, and then swells and compresses the nerve, that affects your muscles of facial expression. You can get weakness or paralysis and a droopy face on one side. There's another critical component to the cranial nerve 7, the facial nerve. It has parasympathetic motor output to the lacrimal gland. This is the gland that produces the tears that lubricate and protect your eye. You'd think that the oculomotor nerve would do that. It doesn't. The lacrimal gland that produces tears is stimulated by the facial nerve. And then mucus glands in the nasal cavity and the palate. There's another part to this parasympathetic motor output. It goes to a couple of big salivary glands that are in the oral cavity. So saliva, you salivate when the facial nerve is active. And finally, the facial nerve, interestingly, brings taste sensation from the front of the tongue. So the trigeminal nerve brings somatosensation from the front of the tongue. If your coffee is too hot, or if there's little bits of eggshell in your scrambled egg, that's the trigeminal nerve that picks that up from the front of the tongue. But the taste from the front of the tongue is facial nerve. Okay. The way you test the facial nerve, real quickly, you ask someone to make facial expressions. So they'll ask you to close your eyes, purse your lips, grimace so you show your teeth, like that. And if you can do all those things and it looks basically symmetric, then you're fine. At least this red part of the nerve is fine. Damage to cranial nerve 7 can lead to weakness or paralysis of the muscles of facial expression, which leads to a droopy facial expression on one side. There's a description for this called Bell's palsy. If you have your facial expression sort of drooping and very relaxed on one side, it may be an indication of damage to the facial nerve. Xerophthalmia, xer means dry, and ophthalmia means eye. So dry eye, and that's because of the lacrimal gland right there. And then if you lose taste from the front of the tongue, that could be a facial nerve problem. Okay. There's the facial nerve, or more correctly, the part of it that simulates the muscles of facial expression. So here it is branching out all over the face, and it's going to, most of the facial muscles are not shown here, but there are some of them. You can see it branching out all over the place. And notice this big blob here. This is the parotid gland, and the nerve goes through the parotid gland. All these branches are kind of hung up on the parotid gland there. Weird. Nerve 8 is our vestibulocochlear nerve. It is a special sensory nerve for hearing and for equilibrium and balance from the inner ear apparatus. And that's all it does. If you want to test a patient's 8th nerve, you test their hearing, make a little sound like that, and see where they can hear it, and if you can hear it on both sides and in back and in front. And if you have a lesion to nerve 8, you're going to get either some degree of loss of hearing, like deafness. You may have loss of balance, which can lead to, well, you can make you fall down, or you can have vertigo, like abnormal sensation from that nerve, abnormal perception of movement, which can lead to nausea, and you can get auditory hallucinations like ringing in the ears. It's called tinnitus. That could be a problem with the vestibulocochlear nerve 8. There's nerve 8 right there. Notice it's coming. It starts. The sensory input comes from the inner ear. So here's the external ear. Here's the apparatus of the inner ear, and the nerve brings that information back toward the brain right there. Nerve 9 is called the glossopharyngeal nerve. Long name, but it breaks down really easily. Glosso means tongue, and pharynx means throat. So this is a nerve for the tongue and the throat. And what it does is neither tongue nor throat. It stimulates the parotid gland. So the facial nerve goes through the parotid gland, but for some reason it's nerve 9 that stimulates it. Weird. It brings somatosensory information from the back of the tongue and the throat. So here's why glossopharyngeal, tongue and throat, right? So touch information from the back of the tongue and your throat is the job of the glossopharyngeal nerve. It also brings taste from the back of the tongue. So the front of the tongue has 2 different nerves for somatosensation, that's trigeminal, 5, and taste, that's facial, 7. But the back of the tongue is glossopharyngeal for both somatosensation and taste. It also innervates baroreceptors and chemoreceptors that monitor blood pressure and blood gases and acidity in the carotid artery. So that's really important. The easy, super quick test is for a patient is you ask them to swallow, and if they can swallow normally, that's good. Glossopharyngeal nerve controls muscles of swallowing, as does the vagus nerve. You test their gag reflex. Since the somatosensory innervation of the throat is the responsibility of the glossopharyngeal nerve, you should be able to take a little Q-tip and touch the back of the throat, and they should feel that, and normally a patient will gag. If they don't, maybe they're numb, and maybe there's a problem with the glossopharyngeal nerve. And maybe you'd lose taste from the back of the tongue too if you had that problem. Here's the glossopharyngeal nerve right here. It comes off the brainstem. Normally in the screens that I post on Complete Anatomy, I'll try to include some of the targets. I didn't do it here because I was in a rush. But it's a little nerve that drops down toward the tongue and the throat, and you'll see it more clearly in Complete Anatomy. Nerve 10, this one is super important, the vagus nerve. Vagus means wanderer, and the vagus nerve goes a long way from the brainstem. One thing it does is it stimulates some muscles of the tongue, not many of them, but a few muscles of the tongue. It stimulates some muscles of the pharynx. It stimulates all the muscles of the larynx. So your voice box, I'm using it right now to vocalize, all of that innervation of the larynx is done by the vagus nerve. That's really important because we rely heavily on our speech, right? There's parasympathetic motor output through the vagus nerve to a lot of stuff below the head. So the vagus nerve drops down through the neck into the chest and even down into the abdomen to stimulate or to control cardiac muscle, pacemaker cells, smooth muscle of the airways, smooth muscle of much of the GI tract as well. So the vagus nerve goes a long way from the brainstem to control smooth muscle way far down in the body. There is somatosensory information, touch, pressure, temperature, pain, from the mucosa lining the larynx. So check this out. The vagus nerve stimulates all the muscles of the larynx and is responsible for somatosensation from the larynx. So to make that easy, the vagus is the nerve of the larynx. Okay? Really important. Somatosensation in the larynx is important because if you swallow something and it ends up in your larynx, you have to cough that out. Like you don't want stuff rattling around in your larynx and then getting down into your lungs. Finally, there are more baro and chemoreceptors. These are located in the aorta that the vagus nerve gets signals from. So you're monitoring blood pressure and blood gases and blood acidity. Super quick, simple test for vagus nerve is swallowing. That also touches nerve 9. If you have trouble with the vagus nerve, you can have dysphagia, which is difficulty swallowing. You can have dysphonia, which is basically boils down to hoarseness, like your voice doesn't sound normal because your larynx isn't working on one side. And you can have tachycardia because the vagus nerve input to the heart basically slows it down. And if you take away that input, the heart just naturally speeds up on its own. Here's the vagus nerve. Notice that we don't even see the brainstem here. It's already dropped out of the skull. It's dropping way down through the neck. It's going down to the heart. It's going to continue past the heart down to the GI tract. It's the only cranial nerve that goes down there. Cranial nerve 11 is the accessory nerve. Very simply, it stimulates 2 muscles. And these muscles are famous from prior sessions, the trapezius muscle and the sternocleidomastoid. You test this by asking a patient to elevate their scapula, that is, shrug their shoulder against resistance, or to turn their head against resistance. Trapezius elevates the scapula, sternocleidomastoid turns her head. If there's a problem with this nerve, the accessory nerve, you're going to see maybe atrophy of trapezius, so the side of the neck's going to sort of drop down, and then they may have weakness in elevating, in shrugging, weakness in turning their head. There's the accessory nerve right here. It drops out of the skull. You can see it branching out into sternocleidomastoid, which is ghosted there. And you can see it branching into trapezius, which is ghosted right there. That's all it does. Finally, the hypoglossal nerve, hypo, under, glossal, tongue. It's under the tongue. And what it does is it goes to the tongue and stimulates the muscles. The way you test is like this. You ask a patient to stick their tongue out, and it should go straight out. If there's a lesion to the hypoglossal nerve, the patient will usually come complain about dysarthria, which is slurred speech. Your tongue is really important for talking, and if your tongue is paralyzed on one side or weak, it makes it hard to talk. And so they'll come and say, my speech is slurred, right? And they'll have trouble speaking as they do so. So here's the hypoglossal nerve. This is a kind of a view from the back and down low, and see it's sneaking down here, and it's going to end up under the tongue and going into these tongue muscles, which are kind of ghosted right here. That's the hypoglossal nerve. This is probably the most challenging lecture you're going to get from me. It was super dense. There's a lot of nerves. It's downhill from here. Hang in there.